Okay, and we also have Jean Miller, I see, is here. Welcome, Jean. Good evening. This open meeting of the Council for Human Services is being conducted remotely pursuant to Chapter 20 of the Acts of 2021. Ensuring public access does not ensure public participation unless such participation is required by law. This meeting will feature public comment.
Yeah, actually, that'd be helpful.
For this meeting, hey, Jean, do you mind muting? For this
sorry.
meeting, that's okay. Council for Human Services is convening by video conference via the Zoom app as posted on the town's website, identifying how you may join. Please note that the meeting is being recorded and that all attendees are participating via video conference. Please be aware that other people may be able to see you, and take care not to screen share your computer. Anything you may broadcast may be captured by the recording. Blah, blah, blah. We don't really need the ground rules. That's great. So I'm going to now call the Council for Human Services meeting to order on November 29th, 2021. And I have confirmed a quorum, and I'm going to ask the council to approve an agenda change. We're going to have the presentation of the behavioral health assessment from Government Performance Solutions, and if we have time, an update from the Director of Human Services. And I'm going to propose that we delay all the other agenda items to the December 20th meeting. If I could have a motion to that effect from the board, that would be great.
I so move.
Okay, in a second.
I second.
Okay, and by roll call vote, Sue Mittenden,
Aye.
Ruthie Tanico,
Aye.
Athlon Sweeney,
Aye.
and I vote aye. Okay, so thanks everybody for waiting. I'd like to welcome Greg and Laura from Government Performance Solutions, and they had come to us, as you remember, some time back when they were in the midst of the behavioral health assessment, and I'm pleased to have them here this evening to give us a rundown of what they discovered and help us think forward as to what the next steps will be in that process, hopefully. So I will, I'm going to wait 2 seconds because Claudia is joining us. And once she's in, I'll have you guys get started.
Okay.
I don't know why it's taking so long, but I'm going to have you go. Go ahead.
All right. Thank you, Brooke, and thank you, members of the council. I'm joined today by my partner, Laura Sigrist. Together, we're going to collaborate and walk through the executive summary of the behavioral health assessment that we worked with you all on from April through September of this year. I believe it was on or around July 9th that we saw you last. And so we want to share our findings with you. Fair warning, Laura's a bit under the weather, and so she's going to try to deliver portions if her voice will hold out. If it doesn't, I will go ahead and jump in. So at any point, if she goes quiet, I think it's just a cough. And then if it is a pattern, I'll go ahead and jump in. I'm going to share my screen, confirm that that's coming through for you all. Got it?
Yep.
Is it in presentation mode?
It is.
Cool. All right, then. This was mailed to you all in advance, and we're going to move through this at quite a clip. Feel free to interrupt us or throw an elbow at any point in time. So we want to share the findings at a high level from the assessment that we worked on from April through September. The slides that we'll share today are just the executive summary, and there's quite a lot more information that backs all of this up. Before we get into the executive summary, though, I did want to cover a couple of caveats that are quite important. First, when it comes to data, we just want to highlight that this is not an academic study and it's not an epidemiological study. We've integrated whatever information is available, either from on island, from within the Commonwealth, or nationwide. And what that means, though, is that sometimes timeframes don't always add up. We may be comparing something from 2016 to 2021, and some other time we may be only using a point in time number where we'd really love to be able to share a trend. We're doing the best that we can with the data that is available. Some data lags by more than a year, and what that means is that the full impact of COVID isn't always represented. So we call that out wherever we can. Spikes in demand that have been driven by the pandemic are real, and we are, like everyone else, waiting to see the long-term impact and how long levels will remain elevated. Third, we've tried to do our duty by pointing out issues while respecting both the people who are receiving the services and those who are providing them. For reasons you'll see throughout the report, it's not very easy to be on either side. It's a tough environment. We tip our hat to the many people who are behaving heroically. They should be recognized for it, but tipping our hat won't actually address these problems. So we've tried to be as direct and practical as we can in pointing them out. And then last, there are really heart-wrenching stories available on the island and no shortage of them. We have not included anyone's anecdote just to protect privacy, but the everyday struggles that we observe and that people share with us make it all the more urgent that the community rally around the findings that we've delivered, and that process is underway. I'm pleased to see Jean Miller here. Jean is helping to coordinate the response. Okie doke. So, end of the caveats. Quick reminder, this diagram is something that we probably shared with you back in July. We followed a disciplined process that involved 9 community focus groups, a slew of interviews, and small group meetings. In total, we engaged face-to-face with 112 different people, and we also received 175 survey responses from the community and 13 complete provider responses. It is noteworthy that we only received 3 Spanish language responses and 3 Portuguese language responses, despite some creative efforts on your part and that of others. We believe that there are nuances to the needs of this community that are not reflected in the report because we just never did adequate participation from those communities. We just didn't get to them in a meaningful way. So in the report, we point that out and encourage potentially different modes of engagement to make that happen. So with that caveat aside, we took all of the community input that we got, put it into this report, and we'd like to just share our thanks for people's help in sourcing the data, explaining how things work and don't work on the island, highlighting the gaps and proposing solutions. We've done our best to be faithful to what people have shared, while also offering some options and ideas from beyond the community. Okay. Laura, let's see how you're doing.
All right, I'll give it a go. Thanks, Greg. So one note about the population estimates that we used in the report, the 2020 census data came out in mid-August, right? Sort of the tail end of our analysis. And that revised census estimation shows an official population of just over 14,000 people for Nantucket, but we know that that is still likely very underreported. So for the purposes of our calculations and some of the prevalence data, we went ahead and used the population estimate from the Nantucket data platform, which is right around 17,000, which again, still may be a little bit underrepresented, but is based on utility and transportation metrics, things that are probably a bit more accurate and up to date than the census data. A little bit about the background information, a little bit about the background data, sort of the reason for action for this report. And you all know all this history pretty intimately, but we looked at a lot of different sources and just sort of picked out a couple of key things that stood out to us as being really clear about driving this cause for action here. We know that Nantucket has a pretty deep history with suicide. Several clusters have occurred on the island over recent decades. We took a look at the 2020 Massachusetts Public Health Department report for suicide statistics across the Commonwealth. And while the data was representing suicide rates from 2017, published in 2020, that data shows that Nantucket's got the highest rate of suicide across the Commonwealth. So that's comparing county to county. We also took a look at some data from the annual risk and attitude survey of students in the 6th to 12th grade. The most recent year of this survey was the 2018-19 Pride survey. It surveys all the students in the 6th to 12th grades. And that's a very thick and meaty report. I recommend everybody take a look at that, spend some time reading through it. There's some really interesting data in there, but here are some things that stood out to us. That report showed that 41 students in grades 6 to 12 are at risk for suicide, and the definition of at risk for suicide matters a lot here. The report asked, the survey question asked, are you thinking about committing suicide a lot or often? So 41 kids answered yes to that question. This represents a 34% increase over the number of kids at risk for suicide from the year before, pretty significant increase. And when you dig into that data, the largest percentage of those kiddos who answered yes to that suicide risk question were your 11th graders and your 6th graders. The report also showed significant increases in substance uses for marijuana, illicit drugs, alcohol, and hallucinogens. And one thing that's really important to keep in mind about this data, this is self-reported statistics. So these are kids reporting their own usage and their own attitudes and risks. We also know that data from A Safe Place showed that during COVID, during the pandemic, there's been a 30% increase in demand for services connected to domestic violence, and a 20% increase in demand for services connected to sexual violence. There are other statistics that validate what the island's families and providers feel. And one of those, of course, is the sense that it's actually really hard to get connected with the provider and stay in a productive collaborative relationship with a behavioral health provider on the island. And we'll talk a lot more about this in just a few minutes, because it's important to put a little bit of data framing around what that means exactly. But succinctly, when we took like the provider to population ratio in Nantucket, that is the number of providers normalized to the population. And we know that that ratio is actually the worst in Nantucket across the Commonwealth. So we also know that the count of providers is exacerbated by turnover and other challenges as well. And then when we think about sort of some of the specific access points to the behavioral health system, we know, the crisis system stands out as a primary entry point. So we know that the lack of access to routine behavioral health care is resulting in unnecessary crises. And that's showing up in emergency room visits, in a lot of cases, transportation off island for inpatient care. And we know that when these crises can be averted or intervened at the front end, there's quite a lot of potential for saving human suffering. We've got opportunities to reduce the demand on high cost healthcare, and of course, those costs of transportation as well. We know that with other parts of the state and the country, social determinants of stress increase, social determinants of health, increase stress. But we also know that Nantucket is pretty unusual, if not unique, in some of those, specifically related to the cost of housing and the degree to which the cost increases those specific challenges. And then finally, we know, based on the response to our community survey, that many community members are reporting that access to care is further challenged by their fear that others might find out. So there's still a history of stigma attached to behavioral health services. Let's talk a little bit about the provider landscape a bit more. So on island, we know that there's a collection of committed organizations and individuals who are often delivering on separate non-integrated missions. We've got about 17 or so confirmed private providers providing access and services to people on the island. Some of those individuals are providing services from off island. And we know that there are maybe a handful or so of other telehealth providers. But we also know that these are not always full-time. They're not carrying a full caseload or a 40-hour-a-week workload. We also know we've got about 6 primary main organizations who are providing behavioral health services. Some of them are providing direct treatment and care, while others are providing referrals and educational resources. So we know and we're familiar with Fairwinds, Gosnold, the hospital, of course, Addiction Solutions, A Safe Place, and then NAMI Cape Cod and the Islands. Something kind of interesting about the variance in perception of access to services, as reported by providers and community members in the survey data. In the provider survey, we heard from the providers, we can get people in the same day, 48 hours or so tops, but the community told us, hey, we're actually waiting for a month or so, or there's always a wait list for me to get in, or I might be able to get an intake appointment right away, but meeting with my actual provider, that's weeks out. So we know that people are working really hard, and yet the community perception remains that services aren't available and people don't feel like they have access. So we know that it becomes really important to develop a deeper systemic understanding and mutual awareness of capacity across the entire system on the island. let's talk about a little bit about the data connected to the provider density itself. So a quick primer on the data that shows up in the charts here in the bullets. Most of the data on this page comes from an effort run by the University of Wisconsin Population Health Institute. And they look at a series of behavioral health access indicators across multiple jurisdictions at the county level, at the state level. And one of the most interesting things that popped out to us as we were looking at that report is this idea around the number of providers as compared to the population on the island. So we're talking about provider to population ratio. We're talking about every one provider can see X number of individuals, and that X is based on the population of a given community. Those green bars there on the left-hand side of the chart in the lower left-hand corner, that shows you a couple of your neighboring counties as well as the statewide data. So on a statewide basis, the provider to population ratio is 1 to 150. It's actually the best in the country. The Commonwealth commonly ranks at the top of most behavioral health access indicators when comparing state to state. And then of course we've got Dukes and Barnstable counties, give you a good feel for, those are very strong, very healthy provider ratios when you compare county to county, not just across the Commonwealth, but across the country. Now, when you look at the yellow and red bars there on the chart, we've got two different estimates for Nantucket. I like to say that the yellow bar there is sort of the best case scenario. And what that's calculated on is a provider to population ratio of 1 to 250. That is based on the census data for population, which of course we know is undercounted. And it's also based on the number of providers that are included in the National Provider Identification Registry, which is administered by the federal department, which we think is pretty overcounted. And we think that because it does not match up with licensing data, nor does it match up necessarily with our scan of the actual landscape of active providers on the island. So the red bar there is what we feel is like a more conservative estimate. This is a more realistic estimate. One provider for every 370 individuals on the island. Okay, so here's the bottom line. By most sources, as I already mentioned, the Commonwealth is an exemplar, the best in the country in terms of many behavioral health access indicators. But Nantucket itself has a ratio that's significantly worse. It's the worst in the Commonwealth, and it's significantly worse than many counties across the country. Not the worst, but it is significantly worse. And we know that shift the ratio for Nantucket to shift that red line, even that yellow line, to be a little bit closer in line, not matching those green bars, but to get it a little bit closer, we would need to add somewhere between 20 to 25 individual providers. And we know that that can be, there are challenges associated with doing that as well. So, and we know that we can feel this in practice. We can feel this when we spoke to people on the island. We can feel this when we spoke to the providers themselves. It's reflected in terms of what we heard in terms of capacity, accessibility, wait lists, referral resources, and the ability to match providers with a need on the island. Okay. Greg, you want to talk about the gaps we found?
All right, thanks, Laura. All right, everybody, here's how we organize the findings. The full report contains a single page for each of the 15 gaps. And if you're curious, if you just sort of click on one of those underlined portions, it's a link and it'll take you to the page that basically talks through for each gap. What is the unmet need? What is the size of the problem? And what are the options that you have to deal with it? What you see on the page, though, is our basic continuum, and we think about these in like 4 categories or bricks of services along the behavioral health continuum. You've got prevention, getting ahead of problems; intervention, getting involved at the earliest point when a problem emerges; treatment, dealing with a problem that you know exists; and recovery, keeping people healthy once their problems have been stabilized. And then around those 4 main bricks are what we call system enablers, and there are 5 of those. These are sort of the mortar that hold the system together. Without that mortar, people fall through the cracks and the system is not strong. So these system enablers are things like collaboration and connection between providers, ways of measuring and improving effectiveness, helping people access supports in a way that is comfortable for them. And so what we find in general is that we often find the system enablers lacking and that causes problems. There's gaps and spaces between providers. So well-intentioned, high-functioning units don't add up to a well-functioning system that works on behalf of all the people. So examples of the importance of system enablers: let's say you have somebody who has an urgent need for an outpatient appointment, or they need support after they return to the island from an inpatient stay off island. Without that appointment, they may end up in the ER in crisis. If we fail to identify an adolescent or a young adult in their first episode of psychosis, or adolescent or a young adult with a substance use problem, that may result in years of interactions with the system that drains capacity from things like law enforcement, the emergency department. And both of those organizations, while fabulous, aren't really organized to deal with these particular issues. So 2 examples. And really the point here is each of these gaps is important. There are opportunities to address each of them. And we also need to make sure that we address the mortar that holds the system together. The lack of that strong mortar creates a system that's ineffective for clients and families. It provides frustration and unnecessary work for your providers and their partners, and it results in unnecessary costs for the system with little return for everybody who interacts with it. So 15 gaps, it's 15 pages. If you haven't read them, I'd encourage you to leaf through them. Some are going to be more interesting to you than others, but each of them is something that was shared with us, and we distilled it in this way, and we got pretty good feedback from the people who contributed to the assessment that this did represent the range and depth of the challenges that the island faces. All right, so we're going to cover just a couple more pages for you. We're going to transition from all the things that are challenging to what you might do about them.
Yeah. Thanks, Greg. So that is sort of a question, where do we go from here? And there's a lot to focus on. There's a lot of potential opportunities. So our team at the end of our assessment in the fall outlined a couple of key initiatives that could be potential launching off points for anyone wanting to tackle the system as a whole, this idea of integrated system of care. None of these on this page are fully developed. That's actually the work of the phase 2 of the work, and we know that that's actually underway right now. But here's sort of where we provide a little bit of food for thought. The first thing is this idea of empowering by creating, identifying, or restructuring some kind of an organization, a grouping of leaders who can come together and lead the integration of the system of care, taking charge of looking at that design from beginning to end, looking at all of the pieces that need to go into support, whether that is funding, resources, policy changes, all of those components that help us understand how the collaboration works, standardized releases of information, data sharing, all of those things that kind of are the backbone of an integrated system of care. The next thing that we think is an interesting place to look at is really to tackle that provider shortage. So the idea is to get, create and then get creative about the how, enhancing access to providers based on the specific needs of the community. So again, we'll say this again over and over, is really being in touch with the needs of the community and then responding to those needs. This is again all about addressing that provider gap. So thinking creatively about how to leverage the reality of the workforce ebbs and flows that are on and off the island already, how to deliver the support needed via other ways that may already be in place that are just emerging, things like telehealth, things like consultative care, and other ideas. The third thing, Greg, if you'll change the slide, that would be great. Thank you. Is this idea of really focusing on redesigning the crisis system and tackling in a much more proactive way some of the school-based support. So really looking at creating a crisis response system that is a unified response. It's blind to payer, and it's actually resourced to stabilize people in the least restrictive settings. And then at the same time, we want to be looking at enhancing all of our school-based supports to meet the specific needs of the youth and families with both linguistic and cultural competency. And the idea here is really targeting efforts at syncing up those deep connections between school-based and community-based care. The fourth thing is connected to community-based care as well. And that is looking at intensive treatment and reintegration support. So something we heard over and over from both the providers and the community members that we talked to is that the resources and services available to step people up in care and then back down again are lacking on the island. So looking for opportunities for more on-island stabilization and treatment before that off-island transport and inpatient treatment is required. That's what we're thinking about here. So thinking about ways to build programs that are already in place and create new ones where they don't yet exist. The fifth idea here is looking at building or modifying facilities to meet the needs identified and the needs that are supported by the data. So once we've designed services for the community that needs them, then the facilities can follow. We might think about things like tele-access hubs that offer some privacy and more stable internet connection. We might think about a mobile care delivery option. We might think about interesting and creative ways to get people together that are pro-social, but not oriented around alcohol use or sort of party culture. We might even think about interesting ideas for transitional housing needs as well. And the last thing there, we want to go as far upstream as possible, right? We know that prevention and effective recovery is really where it's at. And those are the things that are going to be helping us target things like stigma reduction, increasing the awareness of behavioral health generally, as well as the specific resources available on the island, and then also increasing that community engagement and reach across. And so the key question here is really, where do we go from here? What are sort of, how do we sum all of this up together? So here's a couple of last thoughts for us, and then we'll open it up for questions from you all. So we know, again, that we've got lots of small organizations trying to serve a relatively small population on the island, and doing so really requires a cooperation across missions and organizational boundaries that don't often help people being served. Sometimes there is this dynamic between cooperation and competition. And so we also know that sometimes providers are changing teams to sort of promote their careers. That's creating sort of attacks on the system itself for both the people who are receiving the services and the providers themselves. We know, and it's worth saying again, that we were not effective at engaging communities of color on the island. And like Greg said, we owe thanks to you all for your creative ideas in getting that done. But we know more work needs to be put into that to identify the right trust channels, and we need to get people at the table, voices at the table in any kind of designing of a system of care. And the last thing I'll say here really is this idea around emphasizing just the lack of that integration, the lack of the integration system of care. So we really emphasize throughout our work that, starting with a small group of leaders to drive the thing forward, who will avail themselves off of lots and lots of off-island expertise, pulling resources off the island who can help with things like specific treatment modalities, regulatory structures, reimbursements that can be enabled, community organization, driving sort of a team approach to get form and function in alignment. And there is lots of good news in this space. So since we have finalized our report, community leaders from Fairwinds, the town, the community foundation, the hospital, NAMI, the provider community, and others have come together, and they're working on designing the structure needed to support the implementation now. There's some prioritization efforts going on, and lots of discussions around what to tackle and how best to do that. So with that, I will pause here for questions, comments, and any other last thoughts.
Brooke, you're on mute.
If you can stop sharing your screen, and then I can see everybody. Thank you. Okay, so do any board members have any questions that they'd like to, or comments? Sue.
In the slide where you compare the provider ratio, so you did a much deeper dive on the Nantucket number. So which Nantucket number would compare to the sort of less deep dive numbers for Massachusetts and Dukes and Barnstable?
Yeah, that's a good question. That yellow bar there is the apples to apples comparison.
Okay. Because we know that the undercounting happens everywhere, and
Sure.
all the same discrepancies. So, okay, the yellow. Thank you.
Yep, absolutely.
Great, thanks. Anyone else from the board? All quiet today. Anyone else? Heather, or Jericho, any questions?
No, I'm good. This is like my third run through this, so
Yeah.
I think I've exhausted my questions. Apologies.
Jericho begin delivering portions of it just because.
Right,
Yeah.
exactly.
So I'd like to thank you guys. This is also my second or third listen to this presentation, and I pick up different pieces every time. I focus on different things. Jean, if you are interested in sharing with us what's happening on this forward motion side of things. I don't
Right. Well, the first thing I wanted to say was that you're very lucky to have Jericho on your committee because he is one of the leaders on our leadership team. So on a regular basis, he'll be able to keep you informed as to what we're working on.
That's great. That's really good.
And so at the moment, we are prioritizing those 15 gaps and seeing which ones we can kind of work on, which are the most urgent to work on right now, and which ones can kind of be done maybe not as much as in an urgent way. But the group is really strong, and there's so much going on in Massachusetts with funding, and we're just learning a lot right now.
That's great. I think the question I would have as chair of this council, what can we do to help in moving forward? And it's not a question that needs to be answered in this moment, but I would imagine I speak for all the board members that we are committed to the health and wellness of the community as part of our mission, and that this is an important, it's a critical piece of addressing some of the gaps in health and wellness in the community. And not the least of, there's a lot of different arenas here in human services, but behavioral health is certainly a critical element of that. And
well, absolutely. And this group doesn't plan on doing any of the actual, they're not going to stay in a silo of doing work by themselves. As soon as some sort of action comes up, it's going to be delegated to subcommittees that will include more people in the community, and certainly your group to support us in areas going forward.
yeah, terrific. Alflin, did I see your hand pop up?
Hi, Brooke. I just had a question for Jean. Gina, is there a place that we can go look to see who's on that board? Or Jericho, would you share with us because I know everyone's tired tonight that we were a little delayed. I don't want to add to this meeting, but maybe you could share with us who's on that board in the future. That'd be great.
Oh,
Yeah,
so-
I mean,
go ahead, Jericho.
yeah, so the way I intended in doing that is each one of my reports would basically include what we're currently up to. And then I'm also going to be doing a couple of short write-ups for a variety of the 4 different gap categories to help popularize the gaps directly. And then when we get to work on addressing those individual pieces, they'll be sort of in people's minds, and we'll have discussed them, at least to a certain extent, beforehand. So I will definitely be including anything that we do with the behavioral assessment leadership group. I'll definitely try and keep as many people in the loop on that one. I think that's something that needs to be incorporated into everybody's thoughts and minds as often as possible. It's a persistent problem, and it needs kind of persistent changes in the way that people look at it.
Yeah, in my experience, when it becomes part of the community conversation is when progress happens. And that really just involves getting as many people who are affiliated or connected in any way to this area of community need, talking about it. And a buzz can be created on Nantucket.
So a press release will be coming out hopefully this week, if not next week, that we finally finalized. And we'll also put out the word. The phase 1 report is on the Community Foundation website in both English, Spanish, and Portuguese, as the hospital website as well. And we're going to be directing people towards looking at those. To answer your question, Ethan, as far as the leadership team, currently it's representatives from the hospital, the school system, Fairwinds, Gosnold, Community Foundation, and private clinicians, as well as Jericho from the town. So I'm not sure if we need to tell names of those groups right now, but that's who's representing the team.
Great. Thank you, Jean. All right. Thanks, you guys. Thank you, Laura, for powering through your, we're back in cold country again for the first time in a long time. It's kind of weird. We're so worried about COVID that none of us caught colds for a year and a half. Any last chance for questions or comments on this? And we're approaching the 8 o'clock hour. So I think what I'm going to do is hold Jericho. Jericho, yeah.
Okay, so I will keep it this extremely brief, but we are at a fairly complicated point, and I think it's very important for me to lay out the vaccine booster thing as quickly as possible, given that there's a lot happening on that front. So basically, there are 3 more clinics for first and second doses on the island that I can guarantee. Those are the Sunday between 12 and 3 clinics. And, oh, sorry, yeah, thank you, Greg and GPS, sorry about that. There are 3 clinics remaining this coming Sunday, the Sunday after, and then the Sunday subsequent to that one. So it will be the final clinic will be the 19th of December. After that, the town is taking at least 1 month hiatus from doing anything vaccine related. Burnout is real, folks. And then as to the pediatrics, right now, pediatrics are being offered through Briar Patch for their existing clients, Briar Patch Pediatrics. And then there are pediatric doses are available through the hospital at a special dedicated clinic. Those are pre-registering for first and seconds. They are on Mondays, and you can get to them through the same sign-up page you have in the past. There is a booster clinic. Sorry, go ahead.
When you say pediatric, are we talking 5 to 11?
Yes.
Or, okay.
Yes.
So 12 and up. Yeah.
I'm not sure if 12 and up are excluded, but I know that it's focusing primarily on 5 to 11 because that was the last opened. So for first and second doses, 3 for adults and 12 plus for the town on Sundays, ending on the 19th. Briar Patch is doing vaccinations for their patients. The hospital is doing Monday clinics for pediatrics, at least 5 to 11, followed with a single booster clinic of 2 hours, also on Monday. We've also spoken with the hospital. They should be either, if they have not announced it yet, they will be shortly, that they're opening additional booster clinics on Wednesdays, tentatively starting this week for a longer amount of hours. Heather gets to hop in and work on those ones as well. So she will hold her record for the highest number of injections for the town of Nantucket and the 02554 area, handily, I might add. And then those clinics are scheduled for the remainder of December. They should be I think it's about a 50 or 100% increase in the number of booster vaccines per week. Additionally, Sunny Daly down at Health Imperatives is doing a lot of boosters and a lot of first and seconds, and we're trying to help out there as we can. So that is the state of vaccination on the island. Very, very, very quickly, I will talk about Omicron, and then I will let you all get back to your Sunday evenings sharing my nightmare. So Omicron is a variant. It was first identified in South Africa. It is everywhere before it was identified. So there are confirmed cases of it here on North America. Omicron is heavily mutated. For example, Delta, which had 2 to 3 times the communicability of wild type or heirloom COVID, that had 2 mutations. This has 30. So it's a significantly different virus. Those mutations are concentrated on the protein spike that causes the infection, and it may escape certain amounts of immune capture. So you can get it pretty easily, even if you are vaccinated. But the hospitalization and death rates are still very low among vaccinated, and the small group studies that I've seen on this suggest it does not have markedly more increased symptoms. It's not a more severe disease. It just seems to spread faster, and it's more mutated. So it's actually easier to pick out when you're sequencing tests. So Omicron is mild, pervasive, spreads quickly, is rather mutated, and is going to be the kind of every yearly flu cycle like we're used to, but it's COVID because it's endemic. Booster clinics should be ongoing next year as well. Town will be starting, we'll be considering starting, if it makes sense for us to get back into vaccinating in a month, then we will do that. But I'm hoping that there is more long-term integration of this into our healthcare system. So it's not sort of an ad hoc government activity every time it needs to happen. So that is it. Is there any questions on the nuts and bolts of how you guys get a vaccine? Okay,
Okay,
if there
thanks.
are any questions on this or other related topics, you can always email me and I will do what I can to help you find an answer. Thank you very much, guys.
Okay, terrific. Thanks, Jericho. Okay, thank you again to Greg and Laura for that great presentation. Thank you, Jean, for coming along as well this evening. If there's no other comments from the board, I would entertain a motion to adjourn.
So moved.
Second?
Aye.
Okay, and by roll call, Sue,
Aye.
Claudia,
Aye.
Athlon,
Aye.
Ruthie,
Aye.
and the chair votes aye. So we are done at 8 p.m. despite the late start. Next meeting is December 20th, Monday. Please let Ann or Jericho know if you are unable to attend so we know we have a quorum. Okay.
And I will not promise to have us start on time, but I will do my utmost to make sure we start on time and kill these gremlins.
Yes. No more Council for Human Services gremlins. Athlon,
Is that 6:30 or 6?
6:30. Yep, 6:30 to 8. Okay.
Thank you, everyone.
Thanks, everyone.
Night.
Greg and Laura, nice to
Thanks,
see you again.
everyone.
Laura, take care.
Bye.
Good night, everyone.
Bye-bye.